Okay. Thank you, everybody, for joining us today for another installment of our webinar series. Excited to bring this topic to you all to look at the use of EMG in detecting the shoulder and different muscle activation patterns using fine wire EMG for the purpose of assisting in rehabilitation. Real quick, before we get going here, I do have a couple quick housekeeping items. So we'll have a question and answer section at the end of the presentation. As we're going through the presentation, please feel free to input any questions that you have either into the Q&A section or into the chat box in Zoom. We'll be addressing those one by one after the presentation is finished. So it is my distinct pleasure to have online with us today some special guests. We have Tanneke Palmans and Kelly Berckmans from Ghent University in the Department of Rehabilitation Sciences and Physiotherapy. As I mentioned briefly a second ago, so we'll be looking at the use of fine wire EMG to understand and evaluate muscle activation patterns within the shoulder complex. So to kick us off, I'm going to go ahead and turn it over to Tanneke, and she's going to talk to us about fine wire EMG in particular. So without further ado, Tanneke, take it away.
Okay, thank you, Zach. So welcome, everybody. I'm very happy to be here at home, but doing the webinar for you. So we'll do a small presentation about fine wire and how we use it at our department. And afterwards, Kelly will present her work, and I think that's very interesting. So, it's working. So, my name is Tanneke Palmans. I'm a human kinetic engineer at the Department of Rehabilitation Sciences, and I work now more than 15 years at the department. And my main job at the department is to help our PhD students with the technical parts of their study. So I come in when they start the study, trying to create a protocol, and if possible, I help them with hardware, software issues, data processing, things like that. And EMG is one of the parts of my job. So a small introduction. Our department have a few research groups. Most of the research groups that are using EMG is our musculoskeletal group in the upper and lower extremity, and our spine group that will cover often deep multi-3D fine wire recordings, but also a lot of other back muscles. Otherwise, we also have a pediatric research group and neurogeriatric and metabolic and cardiovascular research group. Just a small introduction about the department. So just want to give you a small overview of our Naraxon hardware that we are using over, 20 years. So I started in 2007 at the department, but they both, before me already, old Maya Systems 1400 for the first EMG measurements. And I'm just gonna move the screen here. And now in 2023, we have already Ultium EMG systems, but also IMU systems. And we also use our old telemetry system still, because it's very good for fine wire measurements. That's a small overview of our hardware. But we're here about fine wire EMG and how we are using it in our department. So we know that we use EMG measurements to access muscle function or biofeedback. But for deeper EMG muscles, we trying to use fine wire EMG. So, I hope I can go back. Not? Yeah. Okay, so that's too much. Sorry. There's a little slow motion on my PC. I'm not sure why. Okay, here we are. So surface EMG, we place them on the skin, on the muscle, and we can measure many overlapping action potentials. I'm really not sure why this is not working properly. My apologies. Here it is again. With intramuscular EMG, we place the fine wire into the muscle between those fibers. One of the advantages is that we can record both interference EMG and single action potentials. Of course, it's important that you don't use fine wire EMG just for all studies, because it's a high cost and it's invasive, so that's not that easy to use. So depending on the study purpose, we use surface EMG together with fine wire EMG. And most of them, often we use them for the deep layer muscles in the body, or muscles that are covered by other surfaces, surface muscles. And if we like to measure motor unit activity. So there are, of course, small advantages and disadvantages. And one of the advantages is that you can do the record single muscle activity. You can have access to deep musculature. So what we often do is the deep multifidi for our spine group. And as Kelly will show, we also use them for the upper limb muscles. Some disadvantages, and that's quite important because in Belgium, we are not allowed to place or insert as a physician, as a physical therapist, to insert needles by ourselves. So we need a physician to do so. Of course, the reposition is nearly impossible, and the subject has a minor discomfort, but that's quite. We never had to stop because it's really hard for the patient. So a disadvantage maybe is that it takes a longer preparation time as well for your subject. So for research, for us, that's not a big problem. But yeah, depending on how much time you have or how many muscle you will capture, it can take up to 30 or 40 minutes to prepare everything. The fine wire electrodes that we are using are disposable paired bipolar hook wire electrodes. And we change between uses a needle length of 30 millimeters or 50 millimeters. So for the deep multifidi, we take the 50 millimeters because often with 30 millimeters, we don't get access to the muscle. And you can see that the endings are uninsulated. So there is the measurement portion, and the wire end at the needle side is hooked. So when you insert the muscle, it stays inside perfectly. So how we insert it, so the physician does that for us, but we always use, of course, a sterile technique. So the patient is explained how the procedures will go. So it's important that we have, of course, the insert point, and we try to base them on the senior guidelines. So we do that to prepare for the physician. Then he will prepare the skin. So everything is sterile and the patient is, or the participant is comfortable. And then we always do the insertion guided by ultrasound. That helps us to see if we really are into the right muscle. So the insertion itself, it has to be a sharp movement and you can't retract, because if you retract, the hook will fixate it and then you can't go further anymore. So you only move forwards. And if you advance, you go in short, sharp steps. In the next slide, I will show you a video from our physician is inserting the muscle into the needle into the pectoralis minor muscle, and it can't play. That's really pity. So, or I can afterwards maybe send you the picture, but I think it's because we are sharing the screen, because it was playing before. So I'm sorry about that. But Kelly has some nice videos as well, so hopefully that can be solved. So when you remove the needle, we try to stabilize the wire, and we check the comfort of the patient that he or she is okay. After that, the physician is going away, and it's all for our researchers, and we try to tape the wires to the skin. And it's important that the fine wire, so the length of the fine wire, you have approximately 20 millimeters left for the contraction, so that if the subject is contracting, the wire can go smoothly into moving into the muscles. Then we create a loop, and we fixate that to the skin with some tape, and that's in case if there's any tension or cable tension on the cable, so you don't really remove the wire from the muscle. After that, we attach the wires to our Noraxon connectors, and as you can see, we have a few of them. Most time we use the springs, the green wires in the middle, where you can attach the end of the connector, one of the wires into one spring and then the other one, and then we cover it with a rubber cover. Another option is to use the small black box, what you can see on the right side, and there you have two screws where you can do the contact piece of the wire into the screw. So after that, we are almost ready to measure. Just some more pictures from how it looks if we are working with the fine wires. Left, there's a nice setup of one of the study participants of Kelly. So she combined as well surface and fine wire EMG, and the others are just some pictures of fine wires. Then we do a small check of the signal quality. And first of all, often, and I'm not sure often, but in our department, we often have 50 hertz noise. And that's sometimes that the antenna of the fine wire acts like an antenna. And sometimes that is because the cover is not going good onto the spring. Sometimes we have to change something, but we check it, and as you can see, if you have a sinus wave, real 50 hertz in the frequency report, we need to try to reject that. We're not trying to reject it within the software, because then you will lose some EMG activity as well. But we try to solve everything on the heart rate side. We also ask the participant to perform a contraction, and that's to see, are there any movement artifacts if we do the exercises, what we are wanting, if we're doing a contraction. So if that happens, as you can see on the pictures, we're going to check if the cable fixation is done properly or the spring connection is done as well. If that's all fine, we can start with the surface EMGs as well, and start finally with the exercises, what we like to plan to measure. After measurements, we remove the wires with a continuous pull. So we don't try to hesitate on the trying to take it out, but just try to pull it out. It's quite pain-free. It's not harmful or painful. And we put the electrodes in the disposal container. So that's all for me at the moment. I hope I give you a clear build on how we do the measurements and the fine wire measurements, and Kelly will now present her work. Thank you very much.
Thank you, Tanneke. So Kelly, you can go ahead and share your screen now, and I'll take you off mute as well.
It should be working.
Yep, all good.
All right. So welcome, everyone. So Zach already presented me a little, but my name is Kelly. So I'm a physiotherapist. I'm running my own practice at home here in Belgium. I'm also associated with the Royal Belgium Football Association, where I'm physiotherapist of the national women futsal team. But for this evening, the most important part, my association at the Faculty of Medicine and Health Science at the Ghent University, where almost 1 month ago, I finished my PhD. And today I'm going to try to pick you up in the journey of my PhD. Because what we did in my PhD is looking to the research and put the research into practice. So where we explore the scapular 3D kinematics and scapular muscle recruitment. So what we know is that scapular movements are possible. Some rotations around the horizontal axis, so the posterior and anterior tilting is possible. You have the upward and downward rotation around the anterior posterior axis, and also the internal and external rotation around the vertical axis. Besides, we have also the translational movements of the scapula, so elevation, depression, and protraction and retraction, but those are less important. We will focus on the rotational movements. And there, to make sure they can happen, there is contraction necessary from some muscles, the scapulothoracic muscle especially. So we have the trapezial muscles with the 3 parts, the upper trapezius, middle trapezius, and lower trapezius, and also the serratus anterior. That's the superficial ones, but I explored also the deeper ones. So we have the levator scapulae, the rhomboids, and the pectoralis minor. Also important in my PhD was the infraspinatus. We explored also that one because the infraspinatus has his attachment on the scapula and acts as a stabilizer. So it was also for us important to explore that muscle as well. So what we know is when someone has an altered movement of the scapula, like you can see here on the video, this person may predisposed to have shoulder pain, but also somebody with shoulder pain can have alteration later on of the scapula. So as a physiotherapist, you should give the best exercises to optimize the scapular movement, but sometimes it's difficult to choose the exercises. So what we do is to look at the scapular muscle recruitment during some exercises, especially shoulder rehabilitation exercises. In the literature, Coase et al. Already published some exercises where she looked at the surface muscle, so upper trap, middle trap, lower trap, and serratus anterior, doing 4 exercises to optimize the scapular muscle balance. So we have the side-lying external rotation, the prone horizontal abduction with external rotation, the side-lying forward flexion, and the prone extension. 1 year later, Kibler also published some exercises, the inferior glide, the low row, the lawnmower, and the robbery. And those exercises should be used in an early phase of shoulder rehabilitation to get back the scapular control. But for both studies, only the superficial muscles were explored, and we tried to also explore the activity of the deeper muscle. So we repeat the exercises using surface electrodes for the superficial muscles, like this, and also the fine wire electrodes, like Tanneke told you before, to get the deeper layer muscles. And as you can see on the video, in the upper right corner, you can see the needle going into the rhomboideae on ultrasound, because they are placed with ultrasound to be sure we are in the right muscle. And sometimes it's even possible to see the wire on the picture at your left side that stays in the muscle belly on ultrasound. Afterwards, a lot of preparation that takes the most of the time, I think, for the measurements, not really doing the measurements, but the preparation takes really a lot of energy and time, but it should be done well to get the most information of your EMG data. So what's also important is to normalize the data, because if you don't normalize your data, it's you cannot compare subjects, or in my case, exercises with each other. So we performed maximal voluntary isometric contractions based on the protocol of Castellane that she published before. And what's about the normalization? Well, we use the absolute value of the exercises and then divided by the maximal value given from the maximal voluntary isometric contraction. And if you multiply it by 100, you get a percentage of your maximal voluntary isometric contraction of percentage of MVC. And sometimes in literature, they use like, they divide the level of activation in low, then it's under, the value is under 20% of maximal voluntary isometric contraction. When we speak about moderate activation, the values are between 20 and 50%. And when it's a high level of activation, the activation values are above 50% of MVC. So looking to the results of my study, so one was about the Coles exercises. So we repeat the superficial muscles, get the same results, where we see a moderate activity of the lower trapezius and the middle trapezius for all exercises, except for the middle trapezius. We have also high activity for the side-lying forward flexion, but low activity for the prone extension. But when we had the information about the deeper layer muscles, we can see that the levator, scapula, and rhomboids show for all exercises moderate activity. Looking further to the results from the exercises of Kibler, we can see that for the isometric exercises, lower and inferior glide, there is a moderate activity of the levator, scapula, and rhomboideae, and a high activity of both muscles in the more functional exercises. The pectoralis minor had a moderate activity in the isometric exercises, and only for the lower, we had a low activity for the infraspinatus. So in the study of Kibler, we had the chance also to measure synchronously 3D kinematics with the EMG. So we had also information about the position of the scapula. So at the end of the exercises, we can see that for the lower, the scapula has a less good position, seems to be anterior tilt, downward rotation, and internal rotation. And for the lawnmower, we had a better position of the scapula at the end of the exercises, namely posterior tilt, upward rotation, and external rotation. So still, when you treat a patient, you have to look what's his diagnosis, in which phase the patient is of his rehabilitation, what's the irritation of the tissue, what's the belief of the patients, etc. But with all those factors taking into account, and what's the goal of your exercises as physio, what you want to give to your patient. Do you want to activate a muscle? Do you want to inhibit a muscle, or do you want to have a proper position? It's possible to get the most optimal exercise program for your patient based on what we know from literature. And so if you look at my results of my study, we can say that some cautions needs to be taken with the exercises of Scapular, for example. If you have a patient in a first phase of rotator cuff repair, we know we want you don't want to put traction on your repair, so you don't want to have a lot of activity of your infraspinatus, for example. Then you should use more exercises like a low row and not the other exercises. Also, it was possible, if you all know the different kinds of scapular dysfunctions, so we have 3 types. It was possible also to put the exercises in those 3 types. When we know that a type 1, there is a more inferior angle prominence of your scapula, so more anterior tilt. We know there is weakness of the lower trapeze serratus anterior and also maybe possible shortness of the pectoralis minor. So we will want to enhance the posterior tilt and deactivate the pectoralis minor. So if you need to choose some exercises, well, we prefer to give the lawnmower robbery, side-lying external rotation, and side-lying forward flexion, because all those exercises show low activity for the pectoralis minor and also activate the lower trap and serratus anterior. When we look at type 2, there is a medial border prominence and also weakness of the serratus anterior, middle trap, and rhomboideae. So there we should activate rhomboids, middle trap, and serratus anterior. So those exercises are most likely to be given to our patient with the most activity of the rhomboids in the robbery. And if you go to under the list, then it's less activity of the rhomboids. And then we have the last type 3, where the superior border is prominent. And so you have downward rotation of your scapula with mostly hyperactivity of the levator scapula. So you want to deactivate the levator scapula, and maybe you should give those exercises. But pay attention, because all those exercises has a moderate activity of the levator scapula. So even though are not really good for type 3 dyskinesia. Besides exercises, we also looked at the 3D kinematics and the EMG activity of the superficial and deeper layer muscles during elevations, especially the elevation in frontal and sagittal plane, where we can see that there is more posterior tilt and more external rotation during elevation in the frontal plane. For the EMG activity, there we can see there is a significant, there is significantly more activation of the middle trap and levator scapula during the frontal plane elevation compared to the sagittal plane. And it's the opposite for the serratus anterior and the pectoralis minor, where there is more activity in the sagittal plane. If you want to know, the levator scapula has moderate activity, and the serratus anterior and pectoralis minor, they had overall low activity. So if you want also to put your elevation in practice, then if you want to activate the middle trap or enhance the external rotation, then you should give to your patient more exercises with an elevation in the frontal plane. If you want to deactivate the levator scapula, then the exercises with or the elevation exercises should be performed more in a sagittal plane. So with all those new insights, still it's not possible to know what's the activity in patients because I didn't include patients in my PhD. And also the effectiveness of exercises on long term were not explored and should be further explored. But we can, with all the information that we get from my studies, still implement the exercises in a rehabilitation program, and also, optimize the choice of exercises within physiotherapy. Thank you for listening.
Thank you, Kelly. You can you can go ahead and unshare for the moment, unless we need to get back to show any of the results. I'm going to have Tanneke unmute as well. Really interesting stuff. It seems like you put a lot of work into evaluating those exercise protocols and trying to push forward the knowledge base, as it pertains to clinical medicine and how you can approach looking at the scapular motions, and of course, for somebody with a dyskinesia problem, identifying which one of those exercises are best suited for the particular issue. So I think that's a great tool set for our attendees to be able to utilize going forward. We do have a couple questions that came through, so that we'll go ahead and start with those before any others come in. I think kind of playing off the talking through the scapular exercises and going through some of the different ones that you recommend for the particular levels of dyskinesis. There's a question that came in asking, has there been really solid research on dosing the specific scapular exercises for the specific dyskinesias, or is general exercise just as effective? They made an additional comment. I get that EMG of these exercises seem to be best for the direction of the dyskinesis, but what do the training or practical studies say? Do you have any comments on that?
I think it's important, like we don't know the effectiveness of those exercises. So I think a next step should be given the exercises and look if there is, let's say there is winging, so the medial border is prominent, and you give all those exercises within 6 or 8 weeks to see if there is a change and the medial prominence go away. But that's not explored with the studies I did. So that should be done in the future. I don't know if I will do that, but maybe somebody else.
Yeah.
But I think it's important that if you know that your patient has prominence, that you give exercises where you know there is activation of those muscles. That's the most important thing you should keep in mind when you give exercises. The same if your patient has hyperactivity of the pectoralis minor. Sometimes they have pain because of that. Don't give exercises who activate the pectoralis minor, because it will maybe aggravating the problem.
Sure. Yeah, and I mean, I think, with respects to kind of targeted exercises versus general functional exercises, obviously there's going to be benefits of both. Certainly if there's a dyskinesis issue and you can sort of isolate that to at least, like you were saying, what's happening, is it the medial border that's prominent, is there a winging that's happening? With the understanding of what's going on mechanically in the body, you have at least the ability to kind of decipher and say, okay, let's start with these exercises to isolate those particular muscles, try and build up strength, and identify if that makes an effect. You wouldn't necessarily go right into a functional exercises that, of course, is going to work out, maybe the additional muscles surrounding the shoulder complex. And as the patient goes through the programming, kind of inject both of those scenarios into their program, not necessarily rely on one versus the other. But again, I haven't seen any particular studies that have looked at, things like, shoulder presses or dumbbell raises or, some of these more general exercise protocols and their effectiveness on, scapular dyskinesis issues. Clearly, the specific exercises have been researched, but I think, that presents another project in addition to understanding the effectiveness of the specific exercises, but also what are the effectiveness of the general exercises that are available too. So any PhD candidates out there, there you go. You guys can take that one to the bank. Couple questions related to the first. So Tanneke, thank you for giving us a brief little Neuraxon history lesson and showing us some of those older systems from many, many moons ago. One of our longtime customers, Phil Page, had mentioned that he still has two 1400 systems from when he first started in EMG, and he was wondering if you still use those systems, and if so, how?
Well, till I think 21, we were still using one. We have also two. And how we use it, it was for one of our pain research studies, where we measured the nociceptive flexion reflex. So we give electrical stimulation to our subject and see how the muscle reacts on the electrical stimulus. And one of the advantages we had with our MySystem 1400 was that we have the analog out. So we could take the data into LabVIEW and use all the programming to create a program. And at that moment, we didn't have the Ultium system yet, and our DTS system didn't have any analog export. So that's why we came back to our older systems. But now we have a few Ultium systems with analog export, so I changed everything to the Ultium system.
Right.
So we are not using it at the moment anymore, but it should still work. And it was a 16-channel system, but we sent it a few years ago back to Neuraxon to check it, so it's still fine. And for that purposes, it was fine. But if you want to do really activities, it's long wires, not that easy. Cable artifacts are there as well, so we are happy that we now can work wireless as well.
Give your subjects a little bit more freedom to move, that's for sure. Okay, moving on. So a question regarding the, Tanneke, you had mentioned that in Belgium, as physios, engineers, you're unable to insert the fine wire electrodes. You require a physician to do that. We had an attendee ask a question, what are the regulations for inserting fine wire needles in the US? And, considering that physios can do dry needling, can they also, insert fine wire EMG? I don't expect you to know the answer to this.
I don't know the regulations within the US. I think it's quite similar, I think, to Europe about that. But I know
in Australia there is no license necessary.
No,
for
they
watches,
can
he do it. Yeah,
he creates his own fine wires as well. So he don't buy them, but he creates them and he insert them by himself.
Wow.
So, but that's Australia. But we are not allowed to. So that's and we, as a physiotherapist, we can do dry needling because we have research about that as well. I'm not sure if every dry needler, how do you call it, can do the insertion properly. But of course, if you have knowledge about muscles, how they are on the body, how they look, use an ultrasound, you can learn it. Of course, it's not that hard. It's really a pity that the video doesn't work. But maybe you can try. But I'm not sure. How the regulations are in the US, of course, but I don't think you can do it without you being a doctor. Really.
The technique is also not the same because I'm a dry needler in the practice, and behind the scenes we tried also to insert a fine wire, but it's not the same. So it's really you if you want to do it by your own and you're able to, and you have a license, okay, but still you need to practice because it's really not the same as dry needling.
And the main thing in our country is that the ethical committee will not allow you to do it as well. So for research purposes, yeah.
Right.
I can try to again. I don't know if you can see.
Yes.
Yep.
And it's like this.
It's a little bit going fast, but it's okay.
Yeah, the videos are a little choppy, but we're definitely able to see the technique. I think, of course, the combination of, using the ultrasound in addition to inserting the needle is another part of that technique that's, certainly different than dry needling.
Because you only have one hand to do it. So you have one sterile hand.
Yeah.
So it's not that easy.
Yeah. In my experience, at least from working with customers in the US, I think it varies by state. And as far as the regulations are concerned, I don't necessarily know if a physician is required, but definitely somebody with a doctorate level training is required. So of course a DPT, versus, let's say, an athletic trainer. And then the times that I have witnessed customers perform fine wire measurements, it has been a group effort, let's say. So somebody sometimes handling the ultrasound while the other person is managing to insert the needles. So there's been kind of a team aspect to it that is definitely kind of adds to the complexity of the system as well. But Tanneke, as you mentioned, there's certainly some major benefits depending on if you need access to the hypersensitivity to the direct innervation of the muscle, or to access the deeper muscles aside from the surface muscles. So kind of got to weigh your options there depending on what you're looking to accomplish, right?
Yeah.
Okay, so next question. So this one should be pretty quick. I think you had mentioned it in your process, but with the hook at the end of the needle, when you pull the wire out and you just do that continuous pull, does that hook just kind of straighten out?
So the hook will straighten out and comes smoothly with the wire out. So that's quite important why you can't retract during insertion, because if you retract, the hook will straighten out and you don't stay within that muscle where you need to be. So when a contraction is, you're not sure you're still capturing your muscle, what you try to measure. So that's one of the reasons why they hooked it. So if it's inserted and then you retract the needle, then the hook stays within the muscle. And if you contract, it stays normally. It can happen that it's still going out, but it's a better way to stay over there.
Yeah, it's like one of those finger traps.
Yeah.
Easy to get in, difficult to get out, right?
That's true. That's true.
Back to talking through the activation and related to dyskinesia. We have a question that came through that looks at or asking about, do you think that muscle activation patterns would be the same in the case of a clinical or a patient population with dyskinesia? Because Kelly, it sounds like you were just evaluating this on a healthy population.
I evaluated on healthy population, so people without shoulder pain, but maybe an important one, the participants sometimes had dyskinesia. So it was, we cannot observe it, but we didn't take it in our analysis or something, because we know also from the literature that there are people who don't have shoulder pain, even they have scapular dyskinesia. So for that, it was not like an exclusion. If the participant had or had not scapular dyskinesia. So in my results, people had also the scapular dyskinesia.
Okay. So that was sort of baked into the process, not by design, but by circumstance. So that's interesting. Two more questions, unless any others come through here. This one's a little bit of a long one, but I'll read through it. So given that a practicing therapist would ideally treat individual patients rather than a generic approach, how can researchers design studies that move away from group responses to identify direct relationships between kinematics and muscle excitation in individual patients? And is this something that you could explore with your existing data? That's a challenging one, but I'll leave it to you to try and provide an answer.
I'm not sure I totally understand the question.
I think rather, given that in a lot of research, right, you're looking at statistical outcomes.
Yes.
That's generally the idea of a research study, is trying to find that statistical relationship across a group. But let's say from the standpoint of a translational research project where you're looking at, okay, how, in this case, these shoulder exercises, obviously there needs to be an effect on the individual patient that's going to have their own individual problems. Do you have any recommendations, or have you thought potentially about a way to design a study that could bridge that gap and be able to, let's say, apply research methods to then use in individual treatment situations?
Yeah. It's difficult with EMG because we know that there is a lot of variability between the participants. So yeah, there is like a variance between men and women, but also the neural drive plays also where you put your electrodes. Okay, we follow the guidelines, but still for the surface you have crosstalk. For the fine wire, maybe you get only a few motor units and they are firing lower than the other one. So there is quite a lot of taking into account. So I think really a good design for EMG, there isn't, if you take every, if you take or you standardize everything as you should, like your electrodes are placed as good as possible, doing the exercises, but you will always have some variance between.
Yeah. No, that's a good point, as it relates to EMG for sure.
It's possible to take it with the analysis. So in your statistics, getting your variability into account, but still that will be statistics and not really in the design of the study.
Yeah, I think it's an interesting question, and obviously, when you're talking about pure research versus clinical practice, that's really where there's a big disconnect because of just the fundamental idea of what research is versus treating an individual patient. But we had a customer for a long time that he really liked to talk about, like, he was treating patients, but in his mind, or at least what he was saying, was that he was doing N of 1 research studies. And so he would look at the patient, what their problems were, identify kind of that plan, that process, how he was using the technology to evaluate the situation and get some of that objective data, and then implement based off of what he's what he learned from the objective evaluations, implement that intervention, and then of course retest and get the results. Now you have an outcome, which of course you can log and you can track, and let's say you do multiple N of 1 studies, and you can see what those outcomes are. But again, considering that every patient's going to have more or less their own issues, it's kind of difficult to stack them on top of each other and say, okay, yeah, my approach was effective, statistically effective this way. So interesting thought, but if somebody, I guess, really figures that out and gets that through into a publication, they'll be in a good position, I think, for that PhD. Was there any other comments that you had on that, Kelly? I didn't want to cut you off.
No, it's okay.
Okay. Let's see here. So we got one more, or actually one just came in as well. First, is there a resource or a reference that explains how to use MSK ultrasound to insert fine wire EMG? They had mentioned that they do ultrasound guided needling at their facility. Are you familiar with any particular reference materials that discuss using ultrasound as it relates to fine wire?
I'm not sure. No, I'm not sure really.
Okay. I had Tanneke, in your slides, you had brought up that table looking at the advantages and disadvantages from Thorsten Rudroff's
book. So that's from the ABC fine wire ABC booklet from Norexon really.
So
and there are some reference in as well, but I'm not sure there's with ultrasound. I'm not sure about that.
I don't think it does either. I think it's particularly related to EMG. We did have a comment from Kelly Robb saying that Parado has a text for fine wire EMG. So maybe there's some information there as well. But I can't say that I've seen anything in particular related to ultrasound and inserting fine wire.
What we had in our department, so the physician who is inserting the needles, it's most of the time the same one. Physician, he was lectured by Paul Hodges. He came over and he taught him how to do it, and we tried to use the CNIM guidelines as well, and then with ultrasound. But maybe the Perotto text is a good idea as well.
Yeah, no, that's we'll have to keep an eye out for that resource. That was another question by Phil Page. So Phil, if you end up finding something, let us know. We'll post it on the website. But anyways, we'll go ahead and cut it off here. I do want to be respectful of everybody's time. And so Tanneke, Kelly, thank you so much for joining us today. It was a pleasure to learn about your use case for fine wire, and Kelly, your research and applications looking at scapular activation patterns and exercise prescription. Thanks again. I really appreciate it, and look forward to the next one.
Thank you.
Bye, everybody. Thank you.
Bye. Thank you very much.